Hello and welcome to the EDU-TALK Diabetes series hosted by EZ, Biotone, and diabetes health and wellness professionals. With the daily challenges of diabetes and interest in health and wellness strategies, the EDU-TALK Diabetes series supports building your wellness community by connecting you with diabetes health experts who share their knowledge and expertise on topics of concern to provide you the tools and resources to support a healthy lifestyle. Today's expert is Linda Lockett Brown. Linda is president of Cinet Registered Dietitians and Wellness. Her eDSMEs diabetes education program is nationally accredited and can be completed online, in person, or over the phone. Her approach empowers people living with diabetes to master 7 key behaviors. She has been featured on TV, radio, and podcasts, sharing nutritional information for health and well-being, and is a former EDU-TALK diabetes presenter whose previous talks can be found in the EDU-TALK archive library on ease-z.com or biotone.com under the EDU-TALK tab in the archive library. Let's listen and learn as Linda shares insights on how diabetes technology has the potential to improve the lives of people with all types of diabetes, discussing current available technology, including talking glucose meters, insulin pens and pumps, continuous glucose monitors, CGMs, as well as inhaled and automated insulin delivery systems. Linda discusses the technology features, addressing who benefits most, barriers for implementation, and overall bottom line cost. And with that, thank you again, everyone, for joining us. And Linda, welcome to the EDU-TALKs. I know this is one of your favorite subjects, so I'm going to exit and I will come back on at the end of the presentation to help with chats, questions, and comments. Thank you, everyone. And Linda, it's all yours.
Well, I am glad to be here, and I really like talking about diabetes technology, and I'll show you why in just a minute. So when you think about a person that's managing diabetes or even managing prediabetes, we're asking them to do a lot. We're asking them to check their blood sugar. We're asking them to take their medicine on time. We're asking them to read food labels, count carbs, exercise, in some instances, give up their favorite foods. And in some instances, we're actually asking them to cook at home. So we have 3 things that we're going to do tonight. One is to look at the currently available technology, and this changes so rapidly that every time I revise my slides, there's something new to add or subtract. I'm going to show you a website where if you or some of your clients are trying to figure out if diabetes technology is right for you or right for them, or which one, there's a really good website. It's totally free, and I'll show you that at the end. And as we go through, what we're going to be doing is looking at what the technology does, but also looking at some of the implementation challenges from the perspective of the patient and the physician. Here is a statistic that I just find totally startling. And basically, 89% of patients with type 1 or type 2 diabetes don't reach their clinical targets for A1C. And A1C is used to be the gold standard for diabetes control. That is now changing with the advent of CGMs, and we'll talk about that later. But there's three things. It's called the ABCs. So you're looking at A1C, blood pressure, and cholesterol. So this statistic says, and this is from the Centers for Disease Control, that 89% of folks with diabetes do not reach the targets. So when you think about type 1 diabetes versus type 2 diabetes, the folks with type 1 diabetes, that is an autoimmune disease, usually, but not always, diagnosed in childhood or in adolescence. And those folks, their pancreas does not make insulin at all or at a very small amount. So they need to go on insulin immediately. They just have to go on insulin immediately. Then we have the type 2 folks with type 2 diabetes. We used to call it adult onset. We don't call it that anymore because it is occurring at younger and younger ages. So even though a person is a type 2 diabetic and they are still producing insulin, many of them are on insulin. So when I go through the presentation, I'm actually going to be focusing on, when we talk about insulin, its use in type 2 primarily. So here's what diabetes technology has the potential to do. It has the potential to reduce the burden of that patient that I showed you on the first slide. It has the potential to reduce the clinician burden, and I'm actually going to show you how. It can improve the quality of care. It can save money because people will be healthier. And one of the biggest challenges of diabetes technology is equitable care. And basically, in a nutshell, who has insurance, who doesn't, and does the insurance pay for the technology? That is definitely a challenge. So just a little bit of terminology so that if you see it on the slide, you'll know what it is. The AID is an automated insulin delivery system. BGM, that's old school blood sugar monitor. CGM is a continuous glucose monitor. We're not going to talk about the lag much. The PGHD, that's patient generated health data. So if a patient uploads their CGM readings to the physician, that is patient generated health data. And I'm a registered dietitian, but I actually have my clients data uploaded to my system. And I'll show you in a little bit what I do with that information. And then the other one I want to point out is TIR. So TIR is time in range, and that's when you're looking at a CGM. And so if we can get more people on CGMs, I see at some point that time in range may replace the A1C, and it's a much better measure. So if you look at what technology is currently available, we're going to divide it into three groups. So one category is glucose monitoring. So two major ways to monitor glucose levels right now, and that's the blood glucose meter, and then we have the continuous glucose monitor. Then when you look at insulin delivery, look at all the methods. There's syringes, there's pens, there's smart pens, there's insulin pumps. There's even insulin that can be inhaled. And if you don't want to do any of that, you can attach a patch to your body and deliver a bolus of insulin whenever you need it. And then the third category, I call them delivery methods. So the GLP-1s, that's delivered in a pen. Inhaled insulin, inhaled glucagon. So we'll look at those later. So if you take a continuous glucose monitor and combine it with an automated insulin delivery system in the form of a pen or a pump, what you actually have is an artificial pancreas. And this has been in the works for a very long time. And part of what prompted these systems to be developed is there were particularly folks with type 1 diabetes. They're like, we're tired of waiting, we're going to do it ourselves. And so there are people that have put together their own artificial pancreas by combining their CGM with their insulin delivery device. And so what is the goal of all of this? The goal of diabetes technology is to get the right technology to the right person at the right time. That's really the goal. And that's a goal that's been established by the diabetes educators. So when you look at diabetes technology, and hopefully by the end of this, you'll feel like I do, that diabetes technology is the best thing since sliced bread. Probably not a good choice, but it is. There are 4 perspectives. So there's the perspective of the patient, the physician, the physician's practice, meaning the electronic medical record system, and then all the folks that are involved in that. And then the last perspective, which unfortunately right now is the driver, and that is the insurance company, whether or not they will pay for it. So when you're trying to pick a device, you are looking at the specific needs of the person's preferences, their skill level, and unfortunately, you have to look at insurance coverage. Now, there's a concept called numeracy. And so it's basically, do you have the ability to manipulate numbers and make decisions about what you did with them? And so when patients with diabetes have been studied, the patients with poor numeracy, those folks have higher glucose values. So when you think, okay, numeracy, well, what are we talking about? If you have to adjust a serving size on a food label, and I've had clients say this to me, I don't really check my blood sugar because if the number's high, I don't really know what to do. If the number's low, I don't really know what to do. So that's related to numeracy. Carb counting, you say counting of anything, adding of anything. Carb counting really requires multiplication and division. If you are on insulin and you have a baseline insulin like Lantus, and then you're going to give yourself a bolus based on the number of carbs that you just counted in your meal, if you don't have a good grasp of numbers, of basic math, you can't do that. And calculating basal insulin can be really complicated. And then there's a thing that I hope very soon will disappear, and that is sliding scale insulin. There are a lot of studies showing that people that are attempting to follow sliding scale insulin regimens are not doing well. And so if you're not familiar with the term, it's sliding scale insulin it's time for you to eat. You would check your blood sugar, and then you would count the number of carbs that are on your plate, and then you would calculate how many units of insulin to give yourself. It is very complicated. And for all of these things that require numeracy, diabetes technology is an answer. So you may say, well, okay, if this is so good, then why hasn't it been adopted more widely? Well, part of it is insurance companies, but the other part is most patients with type 2 diabetes are managed by primary care physicians. It's like over 90%. Primary care physicians, that is actually the topic of my doctoral research. I've developed a training program for primary care staff to know what to do with diabetes technology. When we look at what the technology has the ability to do, if you look on the left-hand side, so here you have technology that has the ability to respond to changes in blood sugar levels. You have the ability to monitor remotely. A lot of my patients that have CGMs, the readings on the CGM go to their children or some other family member, so that if there's an alarm because of low blood sugar or high blood sugar, there's a family member that is automatically notified. A lot of times we're asking people to do things, change their 7 behaviors. We're asking them to do that. Well, the patient wants to know, well, if I do this, how will I know if it's working? Well, diabetes technology has an answer for that as well. If you look at the HCP, that's the healthcare provider viewing trends, there's an X in every box. There's an X in every box, but the functionality is there, but the doctors and their staff may not be trained to actually use it. And then last but not least, you can see if they're actually following the treatment plan. So I want to do my little legal disclaimer at this point. I am going to use brand names, but I am not recommending any product. The use of brand names is for information only. So we're going to start with blood sugar monitors or blood glucose monitors, and you've probably seen these. And if I have a client that does not have a CGM and their blood sugar is out of control, their A1C is 12, 13, which is really high, it means their average blood sugar is over 200 most of the time, I'm going to be asking them to check their blood sugar at different times during the day. And by doing that, it helps me to tailor what time they should be eating their meals, what time they should be eating their snacks. So that's a lot. And usually people look cross-eyed at me when I ask them to check their blood sugar 4 times a day. And so patients don't like to do that because it's inconvenient, it hurts. The provider, you tell somebody to check their blood sugar, well, unless the person writes it down on a log and brings it to their doctor's appointment, the provider doesn't know what their blood sugar was. And then the last one is many insurance companies will say, you're type 2 diabetic, you get 30 strips a month. Well, if I'm asking them to check their blood sugar 4 times a day, then 30 test strips is just not enough. So I just want to point out there are some substances that can interfere with blood glucose monitoring systems. So acetaminophen, Lasix, which furosemide, which is Lasix, which is a diuretic, vitamin C, uric acid. If someone is anemic, so if their hematocrit is low, then the glucose readings are going to be wrong. They're going to be falsely low. If they are dehydrated and their hematocrit is high, then the glucose numbers will look higher. So what are some of the considerations when you are monitoring? So looking at the type of meter, what it does, how much memory, how long does it take to get a readout? Those are some of the factors. If a person has low vision, there are blood sugar meters that are really large, have really large numbers. And if those aren't large enough, there are blood sugar meters that actually talk. So once you take the sample and you get the reading, the monitor will actually say what the number is. So even if you have poor eyesight, it can talk to you. Then there are the Lancets. When I first started working in diabetes, we were in a clinic and we had 14 different blood glucose meters, and I took them all home and I did a little experiment. I took the meter, I took the instruction book, I followed the instruction book and tested my blood sugar. At the end of that weekend, I understood why my clients looked at me cross-eyed when I asked them to check their blood sugar 4 times a day. So one of the solutions to that is to use a smaller needle. So when you're looking at the gauge on the needle, the bigger the number, the smaller the needle. So the other issue with the Lancet, which is actually what you stick yourself with, is how big is the needle and how deep does it go? So there are all kinds of Lancets, and the ones that I like the best are the ones that allow you to adjust how far the needle goes in. So there's the issue of the actual thickness of the needle. The other issue is how far does the needle go into the skin? So these are just some examples of the different options. Now, I took the slide out and then I put it back in because I put it back in because if you have a patient that is 55 or older, they are probably on 5 or more medications. So diabetes technology actually has some features to it that can help these folks manage better, because you may be able to change some of the scheduling so that there's less risk of negative interactions. So now I want to talk about continuous glucose monitors, abbreviated as CGM. Continuous glucose monitors take over 1,440 samples a day. There's over 1,440 readings every single day. And we'll show you what happens with all of that data. But if you look at showing the rate and direction of glucose change, can't do that by pricking your finger. Time in range, you can't get there with a regular blood glucose monitor. The last one is one of the keys for me and for my patients, and that is you set the meter, you set the CGM to alarm at certain levels. So some people's low level will be 70, some people's will be 60, some will be 50. That's really important if you have someone that lives alone, to be alarmed, to get an alarm when their blood sugar is low. You also need to get an alarm when your blood sugar is high so that you take action. So what are some of the ways? Just want to show you some of the ways that CGMs can help with diabetes management. One is you can look at the trends. So I'm going to show you some charts in a minute. And I actually take these charts. I go through the charts with my clients, and we use the charts to tell us what time the snack needs to be, particularly if they're having lows. Then the snack needs to be 30 minutes before the low usually happens. So that helps you manage, well, actually prevent is better. You can prevent low blood sugar reactions. You can prevent elevated blood sugar. with the information that you get from a CGM. So these, because you can customize the alarms, it's very flexible. So the research is showing that people with CGMs have better A1C, they have fewer highs and lows, and they have less diabetes related distress. We know that when a person is under a high level of diabetes distress, that their blood sugar control tends to disappear. So this is a quote from a real person, a real patient that has a CGM. And what I want you to see in this statement, it says it helps me to focus on what I love to do rather than worrying about my next finger stick. And so for this person, it was a game changer, and it's been a game changer for a lot of my patients. So what is a CGM? So you get the sensor, you apply it to your arm, usually the back of your arm, and where you put it is actually important, because you want to put it in a place where if you roll over while you're sleeping, the sensor is not involved when you roll over, because if you roll over and it compresses the tissue, then you're going to get a low reading. So you have the sensor collects the data, and then the data goes to your smartphone. Now, in another 15 days, there's one of the CGMs going to be discontinued. And it was a CGM that required you've probably seen people kind of pass their phone over the sensor. Well, that's not going to happen anymore. It's Bluetooth enabled, and the numbers go directly to your cell phone, or, well, to your cell phone and whoever you designate. So this is something that's really confusing to people. And I have a client that's an engineer. He was an avionics engineer. So he's really accustomed to precision, because if it wasn't precise, the planes would crash. Well, biological systems don't have to be that precise. But when you are monitoring blood glucose, you're taking a sample of blood. So blood glucose monitoring is actual. That's the actual number. When you are using continuous glucose monitoring, if you look at the picture on the right, you see that the needle does not go all the way down into the bloodstream, into the blood vessel. It is actually measuring the tissue. Is called interstitial fluid. Is measuring the fluid in the tissue on the outside of the blood vessel. So why is that important? That is important because there's about a 20-minute lag between the level of glucose in the blood and the level of glucose in the interstitial fluid. Now, for most occasions, that is not even important, but it does become important when blood sugar is low or blood sugar is high, particularly if blood sugar is low. If the CGM alarms because blood glucose levels are low, then you need to check your finger and use a blood glucose monitor to check your actual blood sugar levels. The reason is, let's say you ate a meal and you ate something, and it's going to take 20-25 minutes for that glucose to actually get in your bloodstream. Well, if the CGM registers low, but you have eaten, your blood sugar may actually be going back up. So before you take a glucose tablet or drink some juice or eat a piece of candy, you want to do a finger stick to see if the finger stick is above, let's say 70. If it's above 70, then you're not going to treat because you're going in the right direction. So just some warnings about CGMs. CGMs do not eliminate blood glucose monitoring. You still need to have your blood glucose monitor with you at all times. So you're going to use it whenever the alarm is triggered for high or low. And that's just because of the lag. So who's the best patient for a CGM? So someone is taking multiple shots of insulin. I have a client that takes long-term, long-lasting insulin, Lantus. They take it, normally you would take it once a day. They take it twice a day. And then they're supposed to check their blood sugar, or some clients, they're supposed to count the carbs on their plate and then give themselves a bolus of insulin when they start eating. That is a lot to do. Anybody with an insulin pump is a candidate. If a person has a lot of low blood sugar reactions during the day, they need a CGM. There are people that have been diabetic for a long time. And so when their blood sugar starts going low, they get no symptoms whatsoever. So these folks, I've had them tell me they were driving, they ran into a light pole. They were walking in a mall and just collapsed because they were unaware that their blood sugar is low. So if they had a CGM, the CGM would start alarming. And if they looked on their phone, they're going to see an arrow that's pointed downward. So then they know they need to check their blood sugar. And so last but certainly not least, if you're not hitting your A1C targets, then you'd be a candidate. So there are lots of different systems, and this information is as of May of this year. And there are different kinds of systems. So one is real-time CGM, that's continuous. The little I in front of the next one means interconnected. So CGM, so it's connected to other devices. ISCGM is the one where you would run your phone over the sensor, but those are going away very quickly. Then there's professional CGM, and that's where your physician would loan you a CGM for 7 to 14 days, and then you would return the CGM to them. And that is a great benefit, particularly if the patient's insurance won't pay for them to have a CGM. I have clients with CGMs, and in 14 to 28 days maximum, with the information from the CGM, we can get their blood sugar controlled. So people leave here pretty excited. And the newest thing on the market, which I'm really happy about, is you can now buy CGMs over the counter without a prescription. So they're not in drugstores yet, but you can go on the websites and order them for yourself. So with the professional CGM, there's two kinds, blinded and unblinded. So blinded is you're wearing the CGM, but the numbers are not going to your phone. So you don't know what your blood sugar is doing, but your doctor does. And then unblinded, you actually know. I think the unblinded is better because it provides information. I have clients that say, oh, I ate a baked potato. My blood sugar was fine. I ate mashed potatoes. My blood sugar was elevated. So that's the benefit of knowing what the numbers are. So with the professional CGM, who would you want to do that with? You would want to do it with the patient. Just a couple of examples. One that has a hemoglobin A1C of greater than 9%. If there seems to be a mismatch between the A1C and the finger stick. If a patient has gastroparesis, meaning that their stomach takes longer to empty, if your stomach takes longer to empty, then you're at greater risk for a low blood sugar reaction. And then I think one of the best uses is you can try it before you buy it. So as of last night, these are just examples of the real-time CGMs, the interconnected CGMs, professional, and then the ones that you can buy yourself. And so you see that there are two that I crossed through the line, and that was actually it's the Freestyle Libre 2 Plus, and actually Freestyle Libre 3. Those are being discontinued, so it changes rapidly. I wanted you to see that CGMs have different features. And so the features that you're going to look at is it approved for insulin dosing? Meaning, can you connect it to an insulin pump? So the way that works is the CGM monitors the blood sugar, sends a message to the pump, and the pump will increase or decrease the release of insulin. There are several that don't require calibration. Patients always like that. The Freestyle Libre can be worn for 14 days. The newest model, the 3 Plus, can be worn for 15 days. So that's basically like getting a free half a month per year. You can set the alarms to alarm every minute, which I would never recommend, because patients get really annoyed with it and they just want to turn it off. There are implantable sensors that can be worn for an entire year, so 12 months. And then there's remote sharing of the data. And then predictive low glucose alerts. What that means is there are algorithms inside inside the device that can predict in the next 5 minutes the blood sugar will be this. In the next 10 minutes the blood sugar will be this. So that is definitely beneficial for folks with type 1 diabetes because they're not making insulin at all. So these are the real-time CGMs. And I'm just going to go over the Dexcom 6 just to kind of show you the parameters that you would look at. And so this one is approved for use in individuals that are older than 2. It only has, you have to change the sensor every 10 days, and it takes readings every 5 minutes. So just an example of what you would look at. Now, remember, this is one of the ones that has prediction. So if you look down at the bottom of the slide, if the blood sugar is less than 55, it's going to alarm, and it does not allow you to turn the alarm off because a blood sugar level of 55 is very low. Because it has predictive ability, it can tell you that your blood sugar is low, your blood sugar is going down, and it is predicted that you will be in a low blood sugar state in the next 20 minutes. That gives the patient time to go and eat something. And so this particular monitor works with several pumps. So now let's talk about the implantable CGM. If you want to see something really interesting, go on the Eversense website and watch the video. There's a real patient on there with a video of what his life was like before he got his implanted CGM and what his life was like afterwards. So literally with this Eversense 365 CGM, you get it implanted and you don't have to do anything for a whole year. So this is just one of the things that the CGM providers did that I just think is phenomenal. They agreed that all of the systems would use a similar reporting format. So I'm really happy about that. So the first thing that you look at on this report is what percentage of the time did they wear it? So we're looking for 70% of the time. Notice that there's a bar on the right and it says time and range, high, very high, high, target range, low, and very low. So if you have an older person, you're going to focus on the lows. You don't want them going low, particularly if they live alone. So there's different parameters for what is acceptable. So what we're looking at as acceptable is you want to have the time in range, the target range. You want that to be 70% of the time. So that's one of the goals. So this particular patient, they were their time in range was 49%. So we got a little work to do. So what would you actually do? You can print out a profile for every day. And so if I was looking at this, I'm looking at, if you look at the 21st, there was some highs somewhere between midnight and 12 a.m. And then on the 22nd, there were lows at the same time. So what I'd want to know is, what did you eat before you went to bed on Sunday? And what did you eat before you went to bed on Monday? So you would want to look at that and then alter the meal plan. So the substances that interfere with blood glucose monitors also interfere with CGMs. Now, I wanted you to see what the patient sees on their phone. So basically, that page that we just looked at in summary form is what they see on their phone. And so these are examples of the arrows. So if their blood sugar level is steady, then you'll just have an arrow. It's just straight. If their blood sugar is going down, then the arrow will point down. If their blood sugar is going up, then the arrow will point up. So the patient always knows where they are trending. So there's a great benefit to the provider because they can take these charts once they know how to read them, figure out what's going on with their patients, and advise them on what changes to make. So these are the two over-the-counter glucose CGMs that are available right now. The one that most of my patients are getting is the Stello, and it works with Android and iPhone. The Lingo only works with iPhone. So that would be one of those factors you would have to consider. And the Stello has a 15-day sensor. So if you wrap it up adequately, you can go swimming up to 8 feet. So now we switch from monitoring glucose to how do we actually deliver insulin? And this is where we have come from with insulin delivery. Can you imagine having to give yourself a shot with that syringe? Look at how big and how long that needle is. So we've come a long way. So in the evolution of insulin pens, we've gone from what I just showed you, to a pen that could track. Then we went to a pen that could track in real time. Then we went to a pen that Bluetooth that information to a pump. And now we have a smart insulin pen that calculates the dose. So you're going to combine the CGM reading with the insulin pen. And remember when we talked about a patient that has poor numeracy? Well, with the smart insulin pen, they don't have to do anything except make sure that there's insulin in the pen. This is what it looks like. One of my clients said to me one time, I love my insulin pen because I can give myself a shot anywhere and no one knows what I'm doing. So wanted to show you a picture of what happens with a smart insulin pen. Notice that the data is being transmitted back and forth between the smart insulin pen and the CGM. So if you have an older client that's struggling with memory and they can't remember if they gave themselves the shot or not, then with a smart insulin pen, they can just look at their phone and they will know. Or a family member can call them and say, I saw that at 2 o'clock you didn't give yourself your insulin. Then we have wearable insulin devices. So this is a bolus only insulin patch. So you would, and see how thin it is? You would literally count the number of carbs on the plate in front of you and then give yourself a bolus. So with this, you just have to be able to put the patch in a place where you can touch 2 buttons. See, there's a button on the top, one on the bottom. You need to be able to push those because that's how you control the dose. This is kind of what it looks like, and there are many places on the body where you can put it, but you just want to make sure that you can access those 2 buttons. So if you don't want to deal with an insulin pen, we have another option, and this is Vigo. So this is an insulin patch. Now, the difference between the first one that I showed you and this one, the first one you can wear it for 4 days. This one is changed every day. So we have insulin pumps. Most folks with type 1 diabetes have insulin pumps, but there's been an increase in insulin pumps for people with type 2 that are also on insulin. So on the left, this is what the original insulin pump looked like. Imagine walking around with that all day. And so on the right, that's what an insulin pump looks like now. So these are just four different kinds. And you really can't say that one is better than the other. It's really, you look at the features and figure out which one will work the best for you. If you don't want to deal with injections at all, you can inhale your insulin. I've looked at the data for inhaled insulin, and you can take a graph of what happens in a normal person that's not diabetic when they eat a meal, and you can look at the graph, and you're looking at insulin release, and you can look at the graph of inhaled insulin, and it is almost identical. So people that can manage the inhaled insulin are very happy because it gives them a lot of flexibility. Now, if a person has a low blood sugar reaction, particularly if they are a type 1, if their blood sugar goes too low, but this is also true of type 2, you're going to need an injection of glucagon, or you can inhale glucagon, And what it does is the carbs that are stored in the liver, glucagon causes those to be released really quickly so that blood sugar can go from, say, 30 to 70 or 80 in a matter of minutes. So anyone that's on insulin needs to always have glucagon with them. So we've talked about a lot of devices, and so now we have the ability to connect them together. So the way it works is you have a CGM, those readings go to an insulin pump. The algorithm tells the pump how much insulin to release into the bloodstream. And then when the blood sugar changes, that information goes back to the CGM. Here's just one example of that, the NPen and Simplera GCM. So those work together. And I told you earlier that if you take a CGM, combine it with an automated insulin delivery system, what you basically now have is an artificial pancreas. So the only thing that is missing in this system is actually glucagon. So the first fully automatic artificial pancreas that was licensed by the FDA was licensed in 2023. So this is pretty new technology. And I told you earlier, the people that had type 1 diabetes, they did it themselves. They did it themselves. And what was happening is they were showing up with this DIY artificial pancreas system showing up in their primary care doctor's office, and the primary care doctor wanted nothing to do with it. So, there's a saying, there's an app for that. Well, that is also true in diabetes. So there are apps that track food, physical activity, blood sugar, how you titrate the insulin. So when you think about that smart insulin pen, it is doing titration. And then you have the automated insulin delivery systems. So we've talked about a lot, but ultimately what we need to do is get the right technology to the right patient. So here's how you make that happen. There's a website called diabeteswise.org, and it has 3 sections. The first section is for people living with diabetes. The second section is a community discussion forum, and it is monitored by a professional so that if someone posts something that is incorrect, it's monitored. And then the last section on this website is for professionals. So if you're a practitioner and you have a patient that's interested in whatever, you can go on this website, put in their insurance, and it will tell you instantly if it's covered or not. So this is what the patient side of the website looks like. And notice the features. There's a device finder, so people can find out what's available. The last thing that we looked at with those connected devices, that will be combos. And then it's just a wealth of information. And then this is what it looks like for the community forums. And this is what the professional side looks like. And that's what I wanted to talk about. There's a lot out there, and it's really, really exciting.
Very informative talk. Linda, if you're able to stop sharing your screen so that we can see you. I did not see any chats come in, so everyone, you do have an opportunity to chat comments or questions. I thought it was very interesting about the dehydration. And so let's say you're exercising or working in the yard and I just have to get this done, and you're not drinking water, and it's summer and it's hot. Then you take a reading. I mean, everything can be thrown off. And
Right.
yet, if you drink some water right at that point, that can bring your levels up.
Well, if you're dehydrated, your blood sugar levels are going to look elevated. So if your blood sugar
Oh,
levels look elevated, the first thing you do is chug as much water as you can. And that basically is going to dilute the blood glucose in your bloodstream. So you want to drink water first.
okay. All right. That seems like an easy solution. I haven't seen any other chats come in. But I would like to let everyone know that tomorrow, by midday, you should receive a follow-up email with a copy of the recording tonight. Linda supplied a handout, and it will also have her contact information. If you do not see it in your inbox by midday, please check your spam or your junk folder. Quite often, the follow-ups end up there. So please check. Also, if you go back into the EDU-TALK Diabetes Archive Library and listen to any of Linda's talks and need or would like a copy of the PowerPoints or handouts, feel free to email me for that information. Linda, do you have anything coming up that people should know about?
We have lots coming up. We have put together a quarterly schedule for the diabetes self-management education classes. If you wanted the online version, you can start that at any time. And we will be starting in January full force with the diabetes prevention. So if you've been diagnosed with prediabetes, you want to go through this program. It's a 26-week program, and we have lots of data to show that if you complete the program and lose 5% of your weight, that all of your numbers will go back to normal. So we are really pushing that. And I actually saw an email last week from Medicare letting people know that both of these services are covered by Medicare.
Oh, fabulous. That will be great. Um, Let me see what else. I would like to mention that Linda will be back in November, on November 11th, presenting an EDU-TALK Diabetes series on you can get through the holidays with diabetes. So that's optimistic and hopeful, and hopefully tips for a happy holiday season. For those of you that are massage therapists or massage professional, on September 23rd, the EDU-TALK Massage Series has presenter Eric Purvis, and he will present on the science of massage. His RSVP is open on biotone.com under the EDU-TALK tab, and Linda's November talk will be posted, RSVP will be posted in the next day or so. So please keep an eye out for your follow-up email. Contact me if you need any past presentations. And Linda, thank you so much for your time and your information and all you share with EDU-TALKs, EDU-TALK Diabetes Series. Thank you,
Right.
everyone, for all you do as well. Please join us again. I can't believe we're steamrolling right to the end of the year.
Yeah.
And be well, everyone. And thank you for joining us. Take care, Linda.
Bye.
Bye.